Thank you so much. Thank you so much, Svetlana. So this is one pillar. The three other pillars would be, one is the endovascular robotic suite, and the third pillar would be a sentient ICU, and the fourth pillar would be rehabilitation. All this completely disruptive things, we are doing it with Time Medicals and many other vendors who would help us to finally integrate these products. And as I said, 1/10 of a cost. This is what we are doing. Now, I would like another person who is here. Yes, yes. Yeah, sure. So welcome, Puneet. Puneet has been an old friend. Please tell us about your innovative approach, Puneet. We see that you've started screen sharing. Yeah, now yes.
Especially for the neurologically intact patients. But the main goal of surgical treatment is to decompress, is to realign, is to correct the deformity, kyphotic deformity, and provide the long-term stability using the screws. So progressive neurological deterioration is generally accepted as an absolute indication. Other strong surgical indications include incomplete neurological injury, spinal canal compromise, anterior vertebral height loss, kyphotic deformity. But even after all this, I would like to say each case is individual. So what are the options available to us if we are having thoracic lumbar fractures? For the sake of completion, the first is the balloon calfplasty. The indication is that only the NTA column is involved. The PLL should be intact. There should be no retropulsion. Sagittal profile of the balloon, AP profile of cement filling, sagittal profile of cement filling. You can see here,
Puneet,
sir,
Puneet,
sir.
Your slides are not progressing. So will you please make sure that your slides are progressing? It's only the first slide that we are seeing.
Okay, sir, can you see this slide now, sagittal profile?
No, we cannot.
Oh,
Only the title. You have to just log out and log in again. Share, unshare, and then share again.
okay, okay. So which slide, sir, you can see right now?
The first slide.
Oh my God, oh my God, oh my God. Please help me. Please help me. Stop share.
Yes, Sankit, we are aware of that.
So sharing again, WFNS, yeah, this one, yeah. Share. No, stop there. And so now you can see my sharing again. And can you see the, just hold on. This is the slide sharing. Yeah.
Go to full screen now, please.
Yeah, I'm going, sir. I'm going. Just a minute. Stop share. Huh? Then. Zoom. Yeah. Share. Yeah. Okay, so slide sharing is this. Sir, can you see my slide moving now?
Yes. No, you have to go to full screen first. Yes, now yes.
Now we can see, right?
Yes, now go to your slide that you were talking about.
So now you can see the slide moving, right?
Yeah.
Okay, so I'll be starting from the beginning, sir. Sorry for taking that much time. So can I start, sir, now?
Yes, please.
Yeah. So minimal invasive thoracolumbar partial corpectomy is a novel surgical approach devised by me, which I'm presenting today. Now you can see the slide moving, right? Hello.
Yes.
Yes, we can see.
Yeah, good. I'm sorry, sir. So minimal invasive spine surgeries have evolved in the recent past, and so have the prognosis in the spine surgeries, right? So almost 90% of all spinal injuries involve the thoracolumbar region, roughly D10 to L2 region. They are divisible into wedge compression fracture, which is the most common, dislocation type fractures, and the burst fracture, which is the most representative of the thoracolumbar fractures. So the mechanism remains vertical compression and the antiflexion. The management of the thoracolumbar burst fractures should effectively correct the deformity. It should induce the neurological recovery. It should allow the return to the work. But the most important thing for the neurosurgeons is the direct decompression, without which we cannot sleep. So according to Dennis, very famous biomechanic, there are three types of instability: mechanical, neurological, and combined instability. He proposed the three-column model, and he told that if two columns are failed, out of which one of the column is the middle column, then it's an instability. Other points for the instability are the disruption of the posterior ligamentous complex and the 50% reduction in the anterior vertebral height. So the indications, despite all the plethora of the information, remains controversial, especially for the neurologically intact patients. So the main goal of the surgical treatment is to decompress, to realign, to correct the kyphotic deformity, and to provide the long-term stability using the screws, percutaneous screws in my case. So progressive neurological deterioration is generally accepted as an absolute indication. Other strong surgical indications include the incomplete neurological recovery, spinal canal compromise, anterior vertebral body height loss, kyphotic deformity. But even after all this, each case is individual. So the options available for us for the sake of completion for the thoracolumbar fractures is balloon kyphoplasty will be my first option. The indications are if the anterior column only is involved, if the PLL is intact. PLL is intact is very important for us. There should be no retropulsion. The sagittal profile of the balloon filling, the AP profile of the cement filling, the sagittal profile of the cement filling, you can see the vertebral, fracture, the cement going inside and effectively, clogging it and joining the both fractured fragments. This is very close to me, this surgery. We call it impossible kyphoplasty. You can see the anterior and posterior fracture fragment of the corpus. they are broken, in between, and the minimal height is only 3 millimeter, roughly the height of the Jamshidi needle. You can see the filling by the balloon and filling the cement, absolutely no leakage. We lovingly call as impossible kyphoplasty. The incision. So the second option that we have for the thoracolumbar fracture is the thoracolumbar complete corpectomy, MISS. So the indications are instability with or without retropulsion, with complete mangling and fracture of the end plates of the disc. Radiological result. This was one of my initial cases in which I have produced just 2 screws. Ideally, I would like to take one more screw above the superior one. So this is the result. You can see the incisions. This patient is having a power of almost 4+/5, bowel bladder involved. When he came to me, it was just 1/5. So we have the complete corpectomy, we have the kyphoplasty. Why do we need the partial corpectomy? It is to fill the vacuum between the kyphoplasty and the complete thoracolumbar corpectomy. It provides as close to the physiological spine as possible, giving rise to the autograft. It simplifies the decision making, and that is why it has the potential to change or modify the management, the classification, the management of the thoracolumbar fractures, reproducible, fashioned by open as well as MISS method, ramifications of the surgery. So decision making is, if the posterior longitudinal ligament is intact, we do the kyphoplasty. If the posterior longitudinal ligament is ruptured, significant mangling of the structures, then we take out the corpus and do the complete corpectomy. But if the cases in which the ligament is ruptured, disc spaces are intact, and there is only slight impingement of the fragment, and most of the structure is intact, in these cases kyphoplasty is detrimental potentially, and complete corpectomy will be like killing the cockroach in your house by a tank. It will be an overkill. So this is the classical case in which we do the partial corpectomy. You can see some kyphoplasty, a fragment which is threatening to go inside the cord, structure overall maintained. So the cases in which the ligament is ruptured, disc spaces are intact, but there is an impingement of the fragment or threatening to impinge, we do the partial corpectomy. In these cases, as I told you, kyphoplasty is detrimental, complete corpectomy is an overkill. So the surgical technique, a word about that. The patient should be prone, midline pedicular markings, incision of some 3.5 centimeter. Now we do it around 2.5 to 3 centimeter. Laterality of the incision will vary with the body habitus and type. You can see the comparison of partial corpectomy, which is medial. It is just outside the pedicle, and the complete corpectomy, which is around 4.5 centimeter lateral to the midline, because the line of attack is more posterior lateral in the case of complete corpectomy. So we will be defining the bony structures using the serial dilators, marking the outline of the pedicle using the C-arm and the high-speed drill. Some pictures signifying what I said. In the third picture, you can see my cutting match head threatening to go inside the pedicle with the same angle on the sagittal profile as that of the pedicle. So we'll be defining the line of attack. We'll be having the different lines of attack in the partial and complete corpectomy. So my microscope will be aligned with the angle of the pedicle. You can see in the second picture that my monopolar is being used to control the bleeding, especially in the pedicular region. So this is on the axial profile, my partial corpectomy, almost 35 to 40% AP, 35 to 40% laterally. It will be leaving a portion medially of the pedicle. Otherwise, my dura will be herniating inside my operating cavity. So when I'll be going inside the body, I'll be using the diamond drill because the bone dust will be clogging the Haversian canal, reducing the bleeding. So my second step will be partial laminectomy to find a plane to push the fragment and finally take down the medial border of the pedicle. Medial border of the pedicle taking out will be the last step. So diagrammatically, this will be my partial corpectomy. I can do a complete corpectomy from the unilateral side also, depending upon how much is the compression on the cord. So the final step will be taking down the impacted fragment into the partial corpectomy cavity using an impactor, giving rise to complete decompression of the neural structures and providing the autograft at the same time. Aligning the sagittal balance and fixation using the percutaneous screws. So this is the pre-op and post-op. You can see the sagittal balance. The outline of the vertebral body has come down to normal. Axial profile, incisions. Happy patient. It's a video. He'll be telling you that I'm very happy. I'm not going to open the video. So the ramification is when we are doing the complete corpectomy, we can do the complete corpectomy only up till D10, as my guru told me. I have done it up till D9, but above that we cannot go because laterally, if you make the incision, 4.5 centimeter lateral to the midline, there will be scapula and it will be stopping me from doing that surgery. Partial corpectomy, because it's medial, I can go up till D6. I have done up till D4, and if you show me the pedicle or D1, I can do the partial corpectomy in D1. It can be used in some cases in which there is a point kyphotic deformity like this, 78 degrees. When he's lying down, it is looking like 90 degrees. I used 180-degree cuts from both the pedicles, effectively making it 360, controlled reduction, minimal invasive method. The patient is happy, home after 4 days. The second thing is if I'm having a L5 fracture, it's very difficult if you do the complete corpectomy, how will you put the cage? Because the end plates are not parallel to each other. So partial corpectomy is the method in which we can do the L5 and we will not be exposing the patient to the intra-abdominal and the retroperitoneal structure potential damage. My country is TB infested country. And by taking out a pillar of the pedicle, I can reach epidurally, I can reach discally, I can reach paradiscally, I can reach paravertebrally, I can take out all the infected, things, and I can just fix it up and down. It will give rise to a lot of relief to the patient. Obviously, the final improvement will be taking only with the ATT. So if you are having multiple fractures, contiguous, discontiguous, right side, left side in the same patient, how do you operate this patient? This patient was having the L1 fracture, one on the right side, L3 fracture on the left side. The power was intact. I did the partial corpectomy both sides individually. I fixed it up and down. The patient was walking the next day. No drains. The patient was absolutely fine. So it can be if there is a fracture, in a body, only the cancellous bone involved. I can use both the pedicles. By using both the pedicles, I can curate out almost 97% of the bone as done by a study, and I can fill that cavity with the bone cement, and I can fix it up and down, and the patient will be good to go if the power is intact. So my results are total surgeries done till date. It's a very broad outline because it's a very small presentation, so I have not elaborated it. Total surgeries till date, 127. Complete paraplegia in those patients pre-op, 20. Paraparesis pre-op, 107. Post-op pain relieved, almost all, 127 patients in various degrees. Improvement in neurological profile, 105. CSF leak from the skin, 0. Meningitic episodes, only 1, that's taken care of by the antibiotics. Superficial wound infections, 2 out of 127, which were taken care of conservatively. They did well. So take-home message is partial thoracolumbar corpectomy is a novel approach which helps to provide a new decisive way of classifying the management of the thoracolumbar fractures. Partial thoracolumbar corpectomy provides a potent weapon in the armamentarium of a spine surgeon, which has multiple derivations, ramifications, and uses, which can help the said clinician in a multitude of pathologies and in surgically different anatomical locations with very limited chance of surgical complications or entering the vital cavities with the reproducible and favorable results. Thank you for all for your attention.
Thank you. Hopefully, this is Dr. Turrell. I'm participating in this meeting from Athens.
I'm sorry, I am not able to clearly hear. Can you please? Yeah.
You cannot hear. You cannot see.
Slightly.
Increase the volume.
Yeah, I'm increasing my volume, sir. I'm increasing the volume of the.
No, on my side.
Yeah, sir. Now it's slightly better. Tell me, sir. Tell me.
You can hear me now? Okay.
Yes, sir. It is better, sir.
Thank you for a very original, I would say, presentation. Can you get me?
It's echoing, sir. The voice is echoing. I'm not able to appreciate, sir. It's echoing.
Yes, call these people. Turn off volume over here. This one is muted. Try now. One of the first. Close. Mine is closed. Mine is closed. Yes, Paresh.
You want to speak?
Yeah, both of us will speak. Just to thank him and yes, thank you very much, Puneet, for this very original presentation that you made. It was a new lesson for many people, I'm sure. And what is interesting is that you have had patients who have had partial weakness, partial paralysis, those who have shown improvement. I'm sure those who are neurologically totally disabled or paraplegic, what is the outcome in these kind of patients after your stabilization? Is there been any significant neurological recovery, even of 1 or 2 grades?
Sir, that's a very good question that you have asked. Sir, right now, a few days back, can you hear me? Can you hear me, sir? Can you hear me, sir?
Yes, you can hear.
You will increase the volume? I cannot hear him.
Yeah. Can you hear me, sir?
Yes.
Yeah. Yeah, it's clear, sir. Now my voice is clear, I hope.
Perfect. It is a problem on our side over here.
Okay, yeah. Sir, a patient, if he has become very paraplegic, absolute paraplegic, it's like a pupil dilated fixed patient in a cranial patient, right? So, so I saw one patient, sir, around 3 months back. She had, I did a complete corpectomy in that case. The patient was having multiple myeloma. And, as I was seeing, the patient becomes 0/5. So within 3 hours, I did the surgery. The patient walked up to me, after 1 month, that was a miracle for me. So I've seen 1 or 2 miracles, but, if the patient is absolutely 0/5, it signifies that significant damage has happened inside the spine and the chances of improving it becomes very less, sir.
Yes. Especially, you see, in the setting of an acute trauma, you have violence. The injury is violent. The kind of case that you talked about, myeloma, it is a slow progressive weakness. Yeah, but without any violence, even if it is within few hours, there has been no violence. So there is a hope and scope for recovery in patients where there has been a gentle progressive compression. Apart, unlike a trauma, where there is a sudden severe violence. And then, of course, we will not expect. But so if he is totally paraplegic, it is a different issue. And if it is incomplete, then there is like you gave an example of a dilated pupil, like you an example of an optic nerve injury. If there is even some light, if there is a progressive worsening, and if you intervene, you can revert. You can reverse the defect. But if it is already well set, and if it is traumatic, acute setting, then the recovery is not expected. Then you are only doing a stabilization procedure. It is very important to talk to the patients and have a proper counseling that they should not expect neurological recovery. They should only expect stabilization and early ambulation.
Absolutely, sir. Absolutely. The trauma, if the trauma has happened and then the paraplegia is there, then it suggests that a lot of damage has already happened. The chances of recovery becomes less, sir. Very well said, sir.
Thank you, Puneet. We will have to continue with our schedule now. And thanks for sparing your time and for sharing your experience.
Thank you, sir. Thank you so much.
Thank you. Yeah. Thank you. And you can stop sharing your presentation. Yes, I'm now announcing the presentation of participation and presentation of Dr. Shikuo. And please, are you ready?
Yeah.
He comes from China, and the title of his talk.
Yeah, I will
He will
introduce
announce.
myself.
Yes.
Thank you,
Okay.
Professor Keating. And first of all,
I
I share my slides. So can you see my slides? Let us see. Okay.
Yes.
I have, yeah, that's sorry, I do the beginning. What about now? It's a little bit slow. Oh, yeah. But yeah, it's a little bit of time now. Hello? Yeah. Hello, distinguished guests and colleagues and everyone joining us today, both in person and online. And first of all, I would like to express my sincere gratitude to the Professor Ivcharin and the WFNS Innovation and Technology Committee for this wonderful event. And I'm particularly grateful to Dr. Vasilios for the kind invitation and for the excellent arrangement and this beautiful place. And it is a true privilege and an honor to be part of this event. And the following, I will share my some of my insights on digital and intelligent neurosurgery and some of our work. I'm from the Department of Neurosurgery, Beijing Tsinghua Changgeng Hospital and Tsinghua University. So my hospital was founded in 2014. It is a new hospital, but the Tsinghua University is a famous university in China and in the world. Based on the 2027, the newest QS World University rankings, the Tsinghua University now is the number 14. And based on the new U.S. News, the ranking, the best global universities rankings, the Tsinghua University is now the number 6 in best global universities. So this is my hospital and my department teams. And today I would like to introduce some information about digital and intelligent neurosurgery. The innovations in medical technology have transformed nearly every part of the healthcare landscape. And in the fields of surgery, robotics and virtual reality, artificial intelligence is being rapidly adopted. And the surgical pre-planning has been enhanced through computer-generated models and inter-operational navigational aids, especially in orthopedics and neurosurgery. And in the last 100 years, there were 3 historical stages of the development of neurosurgery. In late 19th century, to early 20th century is it was so-called the classical neurosurgery. And then the micro neurosurgery era and the minimally invasive or precision neurosurgery. And all these eras based on the instruments and devices development. And now we are entering the digital and intelligent neurosurgery era. So I will introduce some new technologies. The first of all is ultrasound. This is the brief introduction of the evolution of ultrasound in neurosurgery. Since 1950s, the early explorations, A-mode ultrasound, and the ultrasound technology developed rapidly, and like the B-mode ultrasound, the transcranial Doppler, the ultrasound navigation, and now the multimodal neuromodulation and focused ultrasound. And now the ultrasound technologies that has been routinely used in operation, like the brain tumors and like the ICH. But it has some cons because during the surgery, the probe's inevitable hand movement cannot stable for the imaging, and the surgeons have to see the screen. So it is a screen-dependent image observation and lack perception of tumor size. But now we use the augmented reality intraoperative for the ultrasound. We use the AR technology, the glasses, to show the ultrasound images like this. We can, with the AR glasses, we can see the lesions just under the probe. And now that we Chinese manufacturers has developed a new transcranial ultrasound technique, and because in traditional ultrasound it is difficult to through the skull, but now this technology has the ability to transcranial to see the structures inside the skull. Usually we use the transtemporal window and the transfrontal window to see the structure of the brain. Like this is the hematoma, and we can see clearly transcranial, not the intraoperative. And this is a use of the intraoperative monitoring transcranial ultrasound. This is a case of brain abscess, and through the skull, through the bone, we can see the abscess, and then under the monitoring of the transcranial ultrasound, my colleague drilled the bone and drained the abscess. We can see the drainage can we monitor the drainage into the abscess, and then we injected the saline into the abscess. So this, to my knowledge, this might be the first intraoperative real-time transcranial image of we can see the brain during the surgery intraoperative through the skull. And we also use the intraoperative CT scan and intraoperative CTA for the vascular diseases and complex skull-based communicating malignant tumors. And another technology is augmented reality for surgery. It's combining engineering and medical science. And it is also very useful for the training and pre-surgery planning. And many centers has tried best to do the like the neurosurgical simulation and teaching. And now this is what we do now in our center. We use the HoloLens and the Metaverse system to observe the anatomy and for the young neurosurgeons training, and then and also do the pre-operation planning and the simulation. And we also can use this system to comparison of different approaches to the complex lesions, such as the aneurysm, like this aneurysm, and we can through the subtemporal approach, terminal approach, and OZ approach. So we can use this system to comparison of these three approaches. We can see the aneurysm's neck and exposure. So we can deeply understand the anatomical structures before surgery. And this is very useful for young neurosurgeons training. And we also use this system for in the OR for surgery. The following are some illustrated cases. The first one is the vestibular schwannoma. We can use the patient's CT data and MRI data for the pre-operation simulation to do the retrosigmoidal approach and simulate drill posterior wall of IAC based on the CT reconstruction, and pre-operative simulation to drill postoperative wall of IAC to expose the tumor based on the MR reconstruction. And this is intraoperative in real surgery. We drill the IAC and expose the tumor and remove the tumor. And we can comparison of these three types of CT reconstruction. The pre-operative CT, we can see the IAC, and this is a pre-operative AR simulation, the drilling, and this is this panel is the post-operative CT reconstruction. We can compare the pre-operative AR simulation and the post-operative CT reconstruction. It is almost the same, and the patient has the good outcome. And the next case is a lateral frontal glioma. And before the surgery, we can see this tumor is located near the Broca's area. So before the surgery, we do the preoperative planning for 3D reconstruction of brain tumor and the fiber tracts, and especially the arcuate fasciculus tracts. It is close to the tumor. So before surgery, we use this system for the surgical planning. And during the surgery, before craniotomy, we can use this system for the visualization of tumor and fiber tracts. And during surgery, after craniotomy, the surgeon located the lesion by visualization of this system. And we can see through the brain, locate and mark the eloquent area. We use the sponge to mark the eloquent area. And to decide which way is safe. And the Medivis system, the Medivis company, in its main page is website. This video is my chief's case. And the next case is post-communicating artery aneurysm. And we can use this system before surgery to simulate craniotomy. And we can see the anterior, the ACP, to drill the ACP to expose the neck of the aneurysm. So this is especially used for young neurosurgeons. And the last case is the subclavian artery occlusion case. This case has the vertebral steel syndrome. So we use the artificial vessels to do anastomosis bypass and to do the carotid subclavian bypass. And before surgery, we can use this system to see through the patient and to understand the anatomy. It is the same process of the neuronavigation. So after the registration and the CTA images, the 3D reconstruction CTA images is we can see the patients see through to understand the anatomy. We also use this system in spine surgery. So this is a case, is AVM case, and we combine these new technologies and in the neurosurgical digital intelligent surgical platform, and empowered by advanced technologies. This is a 34 years old case patient. He presented with a single seizure. We can see the lesion located in the left parietal occipital area. And this is in AVM. And this is a preoperative, the AVM grade is Special Martin grade 3. And this is a surgical position, the patient's position. And we performed this surgery in the hybrid surgical OR room. And this is an intraoperative CT. Before surgery, we do CTA reconstruction to locate the lesion, and then use the augmented reality techniques for the navigation. It's a same process of the registration with the traditional neural navigation systems. And we can see through the skull and locate the lesion. It is better visualization than the traditional neural navigation systems. And during the surgery, we use the AR enhanced ultrasound system to see the lesion just under the probe. And then we resect this lesion under the exoscope. And this is the surgical process. In its main artery feeder is the branches of the middle cerebral artery. We temporarily clip the feeders and then divided the lesions. And finally, we cut the draining veins. And this is the lesion. And then we do the intraoperative CTA. To see to confirm the lesion totally resected. So the patient tolerated the procedure well, and he had no new symptoms or complications after surgery. So this is a better illustration, a case for the combined new technologies. And at last, this is my conception of the future surgical OR room. We can combine all these technologies using the augmented reality centric and to create a transformative surgical platform by establishing augmented reality glasses as the universal hub for the operating room. The core innovation is to integrate different technologies, including neural navigations, neurosurgical robots, robotic arm-mounted exoscopes onto a single AR platform. Because now the many devices are the robotic arms, so we can control these devices using the glasses, and simultaneously, the real-time imaging from intraoperative CT, MRI, and ultrasound can be fused and streamed directly to the surgeon's view. The AR glasses will serve dual purposes as a see-through device visualizing patient anatomy, and as a head-mounted screen for displaying critical data. And this unified interface will allow the surgeon to intuitively control robotic arms and exoscopes while maintaining an unobstructed information-rich view of the surgical field. So at last, the digital intelligent neurosurgery, the concept is use technology for the enhancement of preoperative planning, surgical performance, therapeutic support, or training to improve outcomes and reduce harm, including AI applications and any future digital modality used in the practice of surgery. And this new paradigm based on these amazing technologies is changing traditional master apprentice system. So the new AR intraoperative navigation method revolutionized the surgical experience. It can help assist the surgeons in navigating complex procedures, offering improved accuracy, reduce the procedure times, and enhance the patient care. And also it is time efficient, shortening the learning curve, and ultimately leading to error reduction. It is especially for the young neurosurgeons. This is my presentation. Thank you.
I know Professor Goi for the last 16 years. So I have always had the good fortune of having him as a brother of mine. And I have always been proud of his work. So you can see the kind of level that he brings into this forum. And we look forward to having many more talks from Professor Goi over the next few years that will be at the Innovation Committee as well as with the Neurosurgery Coach. And with that, thank you very much, Professor Yi, for an excellent talk. Very, very inspiring. And I will ask Professor Keki to give his talk with that.
So, whilst the pen drive is being
Yes.
June,
2026,
yeah,
June. Greece.
yes.
Complication.
Yeah, is it the keynote?
Huh?
Is it keynote?
Yeah.
Okay.
Yeah, 20 minutes.
Yeah.
Yeah, just share the screen share. Screen share. Screen share.
This one?
Go to the first slide. Yeah, okay, all right. Okay.
We'll need to share this. Are we sharing this screen? Huh?
Yes,
The screen is shared?
Not yet, though.
Can we? Yeah. You can go to the PowerPoint straight. You can go to the PowerPoint.
This will be one before this.
This,
Yeah.
and
No, first slide.
Now this?
This is the first slide.
This not.
Yeah.
Operative.
Okay, shall I start?
Yeah.
Audio is on.
Yes.
Okay. So here we are seeing a most unconventional meeting from the Technology and Innovation Committee headed by Dr. Cherian and his co-chair Albert Sufiano. It's an honor and pleasure to be here, and I'm talking to you directly from Athens, and hope we can reach the messages to you. We already have seen all the good news and the great things happening with modern technology, but as a person who has seen it all, done it all kinds of complications in my life, I think it is important for me to add a little wisdom and share the problems that can occur and the disadvantages that can happen whilst we are racing literally through the modern technology. Of course, it is inevitable that we will need it, but it's also important to be cautioned about its use, misuse, and abuse. At the outset, I must thank my friend, Dr. Vasilius, for his extreme effort and intensive care that he has put into this, arranging this meeting, the first one of its kind, from the beautiful place in Athens, where we are located. It is not a typical studio, but it is absolutely in an outdoor area with a flowing breeze, swaying trees, and just overlooking the beach. So, Dr. Vasilios, thank you very much. I must, of course, thank my dear friend Ip Cherian, whose brainchild this conference is. And without his foresight and his extreme dynamism, we would not be seeing this day. And what advantages he has brought, not only to this committee of innovation technology, but also to the future that we are looking at. It has already become the present. And I must give full credit to his imagination and his vision for bringing this amazing conference right to our doorstep so that no one is left behind and that we all can work together for the welfare of mankind. So I'm going to talk about complications avoidance in this era of technological advancements. And therefore, only the man who knows exactly the art and science of the past and present is competent to aid in its progress in the future. Something said by a pioneering surgeon, Bill Roth, more than a century ago, 2 centuries ago almost. And I continue to be the person who has seen the past and present and who is now gingerly entering the progress of the future. So why do we talk about complications? Every neurosurgeon experiences them. The complications affect patients, families, surgeons, and institutions. Learning from complications remains the cornerstone of progress, without which we would not be able to stand today. Prevention is superior to management, and therefore, the best complication is the one that never occurs. That's a dream. So technology does not replace surgical judgment. It amplifies it. So when used widely, it can prevent complications. And when used blindly, it creates new ones. Medical science has evolved most notably during the past 100 years. And I was a part of the pre-CT scan era when we used to investigate patients by angiography and ventriculography and myelography.
Okay.
And then...
Okay, your talk is not being shared.
No.
See?
How do I know it? We'll go to full screen first.
Yeah, please. Not share the live. It's shared. It's shared now? Yeah.
Yes, let's say. We'll go back. I'll continue.
No? Okay.
Yes, it is shared now.
Full screen. Okay. Yeah, so as I was saying that medical science has evolved largely during the past 100 odd years, and we started in the I personally started in the pre-CT era when we did angiograms and ventriculograms and pneumo encephalograms to make diagnosis of various lesions in the brain, both tumors and vascular ones. Yes.
It's okay.
You can enlarge it.
No, it is
Okay. So
screen to everybody.
So until 70s, when advanced imaging appeared on the scene, neurosurgery was practiced in a relatively primitive manner or a modest manner. And then we got onto the microscope. I started doing microscopic surgery in the late 70s when it was introduced by a couple of German neurosurgeons to me. And then I went on developing it in the country, in India, and from there on to various other parts of the continent and the world. So sources of complications can be divisible into patient factors. That means we consider various factors that are listed over here. We also have disease factors which can also alter or modify our complication creation, and then the surgeon factors such as experience, fatigue, judgment errors. However, we are also dealing with system factors like equipment failures, team communication, and technology can help address each of these important domains. Historically, we initially had clinical examination, just simple as I mentioned to you, very primitive tests, and it required a lot of computerization in our own brain to imagine where the lesion would be inside the brain without CT scans. But now we have higher resolution MRI, functional imaging, neuronavigation, robotics, and assisted planning, AR assisted planning, augmented reality, high-end visualizing scopes. And the result is that we see greater precision and reduced morbidity, ultimately having improved outcomes. So medicine has always been built on past giants, and CT scan and MRI revolutionized neurosurgery and allowed lesion localization, disease detail, tailored treatment, parallel refinement of instruments. So 70s to 80s, we saw a happy marriage of imaging and technology, both developing simultaneously. So on one hand, there was work done by individuals in the advancement, and on the other hand, we had progress in technology. So there was boom in imaging, which brought a rapid surge in medical and surgical technology. And these improvements helped in the speed and precision movement of management, both in terms of diagnosis and in terms of imaging and management. So we had all these recent advances which you already know. So there's no point in even reading them. I'm just using it as an introduction. So in the past, the future was being continuously evolved and shaped by three things: visualization, instrumentation, and collaboration, interdisciplinary collaboration. So we had enhanced visualization, real-time feedback, precise guidance to minimize patient injury and improve outcomes. And the focus ahead was, as I said, safety, precision, personalization, and digital integration. So neurosurgery is now being transformed rapidly by technologies like AR. As the word suggests, AR means augmentation of our perception of reality by overlaying digital information onto the real world in real time. On the other hand, virtual reality is not real, is virtual. It exists virtually and not physically. So AR is being now used every day in our regular practice by virtual navigation. We have got 3D systems. We have exact, precise anatomical knowledge, which guides us to avoid critical neural and vascular structures and enhances target planning and reduces cognitive effort. So AR also has limitations. It does not account for intraoperative brain shift, positioning changes like CSF leak, and therefore we have increased AR alignment errors. Now, intraoperative imaging will help to overcome some of these things by MRI, CT scan, and intraoperative ultrasounds. So real-time intraoperative imaging is done, allowing us to crucial real-time adjustments and ensuring greater positioning. The limitations of MRI, as you know, are that the cost is very high. Is printing it prolongs operative time and reduces MR compatible equipment. So we also have potential complications from head immobilization, limited accessibility, and all that you see on this slide. The light is falling too much on it. The light.
Yeah, so you can bring it here to the table. This is the another problem with the outdoor meeting.
Yes. Okay.
Better now?
Yeah. Ultrasound has been used now extensively from the earlier because you saw the evolution of ultrasound, and we have understood that better the image quality, better is the utility of the ultrasound, and better the extent of resection. So, and you see the lower slide on the left-hand side, that better the visibility, you have better results of extreme surgical excisionability. And as that gets zooming on, responding.
Yeah, that's it.
Yeah. So it's not moving. It's not moving. It's not moving.
Yeah.
Okay. Yeah. So we have limitations of 2D ultrasound, the quality being affected by, but now, so the problem is that we have unconventional planes of imaging and absence of full head views, and therefore there is lack of image orientation. We also have inability to spatially correlate the exact 2D plane of image and surgical cavity, especially when you are looking for small tumors or residual lesions. So we are unable to correlate these images taken over time, serial temporal correlation. This slide compares the intraoperative MRI with intraoperative ultrasound, and we see that ultrasound has significant advantages. For example, examination time is very little. You can have multiple examinations. You can have alteration of surgical outflow or workflow without disturbing the patient information. And we have additional infrastructure. As we all know, the cost is minimal compared to MRI. Surgical team is very convenient, and there is great comfort, especially in awake cases. The MRI, of course, has the advantage of having very good resolution and very good orientation of the image. And we know that MRI is not dependent on the user, and therefore that's a great advantage. Whereas ultrasound has significant disadvantage if the user is not user-friendly, so it has to be experienced user. So image resolution is good and very good now, as it is getting better and better, especially if navigated. So we go on to electrophysiology monitoring, which everyone is using today. And I see that real-time assessment of nerve function is very important during the procedures, which enables the surgeons to detect and prevent neurological recovery early. So this is a well-known thing now. So there's nothing for me to add to this, but I will tell you the disadvantages. I'll show you this case. An example is an acoustic tumor, vestibular schwannoma, large one, and he has this intraoperative monitoring. Now, whilst we are monitoring, we had very good resolution, continuous monitoring of the 7 and the 8 nerves, which are the most important nerves over here. You see his preoperative audiometry is very good. And here, therefore, the job of our preservation of hearing, and therefore the electrophysiology has to be very accurate. And you see the next images, all showing various steps of the operation and the various electromonitoring. So throughout the monitoring, as shown, that 7th and 8th nerves were completely preserved, as you also see in his surgical videos. However, immediately post-operative, we realize that whilst his facial nerve is intact, his hearing has gone down, despite auditory monitoring showing otherwise. So immediate post-operative, he has lost his hearings, and he has, when we did his brainstem auditory system, that also shows no response. So we were a little disappointed that in spite of all the efforts at operations and in electrophysiology, so there's a distinct disadvantage. Uh, and therefore it calls for a good collaboration and good experience by the electrophysiologists. So post-operative, immediate post-operative, there was a steep fall, but we were fortunate because we had preserved the hearing at least at the time of surgery. You can see after 4 months, the patient has got back his hearing. Another example of this gentleman, another large tumor, decided August 24, 2 years ago, and immediate, again, monitoring showed no problem, 7th nerve, 8th nerve, both preserved. But immediate post-operative, you see what will happen. He has developed the 6th nerve and 7th nerve palsy. So I was again disappointed, took him for an MRI, and you see, the MRI shows a large hyper-intense shadow in the cerebellum and in the cerebellar peduncle. So we continued to observe him, and after 3 months, we saw that he recovered in his facial and in his abducens palsy. Now, what had happened over here is that during surgery, there was a perforator spasm of pica, and he developed the pica syndrome, partial pica syndrome. And that's why he developed the 6th and 7th. And you can see post-operatively that the MRI continues to show a damage to his structure. However, clinically, he recovered from his 6th and 7th nerve palsies. So we have these kind of problems which we have to be very careful about. I'm showing you one more case of intramedullary tumor. It was going into the medulla from upper cervical cord. And this girl had come to us with a instability, with an imbalance, preoperative motor weakness. And so I'm doing this intraoperative video showing the separation of the posterior columns and gradual complete removal of this tumor, maintaining a clear field of vision, clear separation, and you can see the tumor coming out in one large blob and then a second blob from the medulla, and complete tumor removal. However, during the operation, I'm now closing the arachnoid. I do a bipolar welding or soldering and then close the dura. During the operation, I was told by my physiologist that the evoke potentials had gone and disappeared. But you saw that I did not pay heed to it. I continued to operate because I was very certain about my technique, neurosurgical technique, and got separations. So post-operatively, this is a pre-operative video. There's a slight imbalance in our gait, and that's the operative video. Immediate post-contrast MRI shows a good removal, and delayed post-contrast shows that there is absolutely no evidence of surgery, virtually. And this is seen 1 month after surgery. This girl is dancing. No posterior column loss, no imbalance, in just 1 month after surgery, after removal of a cervicomedullary. And in spite of that, during the operations, so contrary, I was told that there were no evoke potentials. And in your earlier scan, I told you, I showed that there were all the evoke potentials present, but we had bad results. And here, all the evoke potentials had gone, and here you see a good result. So technology has to be carefully used, in other words. And then false positives and false negatives are a limitation, and they can impair, also limit the extent of tumor resection. So you have to be the surgeon has to be very sure. Yeah. Okay. Okay. 5 minutes. So we'll go on to robotics and AI, and you've already seen beautiful presentation of Dr. Go. So we have AI enhancing the diagnostic analysis of imaging data, facilitating highly precise procedures. And while robots are offering precision, complications can still arise from reference frame errors. And we have artificial intelligence, which is helping in diagnostics, assisting in analyzing medical images and more precise diagnostic information, making surgical planning and treatment better. So AI has been used for a very long time in radiology and imaging, and it was first approved in 2017. And so there are huge benefits, as you can see over here, in AI radiology. But AI may not replace radiologists. But as you see, the old crow cannot be replaced, but the modern crow knows how to use it. So radiologists who will use AI will replace radiologists who do not use it. So you have to keep upgrading your skills. AI has challenges with data quality and bias. There are inaccurate predictions, patient privacy and accountability. There are legal hurdles. There's lack of transparency, which is hindering trust. And there are organizational obstacles, workforce training, and reluctance to adopt new technology. So we are facing these challenges, but we know how to overcome them. So we must remember that over-reliance on AI is diminishing surgical experience or surgeon experience, resulting in error. So the effectiveness is that we are having new surgical paradigms, and though these also introduce new challenges that require careful management. And minimally invasive techniques and newer techniques will come with the new surgical paradigms. There will be enhanced visualization and 3D visions, navigate through small corridors. We will have specialized training. So these will also introduce new challenges that will require careful monitoring and management, training and experience. There are steep learning curve, and which will require honesty. And we have focus on minimizing tissue damage through tools like dynamic refractors and tubular systems. Though these will also introduce new challenges that will require careful management, as you see in these dynamic tubular retractors. There will be some training required because there will be shifts, ischemia, hemorrhage, infarction, all those kinds of things which can damage nerves and often blood vessels. We are facing threats by AI to human health, and AI is now getting smarter and learning to lie, learning to scheme and threaten its own creators. So this is likely to sabotage and blackmail, and we have to learn how to overcome that. So AI might let you die to save itself. So we have to now keep pace and keep improving our information and our ways to combat that. We have resource limitations, which will be spoken about a little later by Dr. Afzal. So we have problems of accessibility and affordability, as in small towns and villages and low-income countries. And therefore, we need to have infrastructure and training in resource-limited regions. And this is the very challenge which has helped which has motivated Dr. Cherian to come up with how to come up with resource-limited capabilities and bring this very modern technology. On our side, we have been sharing these lessons learned by having these complications meetings, ICCN, International Conference on Complications in Neurosurgery. And we have published books already. We have had already several conferences and done 2 books. And the next complication meeting is going to be in Rimini in October 18th to 20th in Italy. So we have continuous learning and the challenges in the future. We have got to focus on proactive strategies, cybersecurity measures, risk management frameworks, ethical guidelines, employee training, and adopting new technology, adopting sustainable practices to mitigate this. The future is these small cameras. Can you see this nano camera? It is half millimeter in dimension. And this is going to be the future. The future is nanotechnology, using nanotechnology, which will incorporate with DNA for better drug delivery. So we will have what we call as nanobots. Targeted drug delivery, payload delivery, disease diagnosis, and cellular repair. This is the future. Nanobots. We have manufacturing. We are continuously improving on that. Controlling and replication, computational disabilities. These are the challenges. But despite them, research is advancing rapidly, and experts predict that nanobots could use mainstream medical use within the next decade. We have holographic room view by virtual reality. Safe human resection of the disease is going to be possible. And we are now working on automatic crane system called Milo. And how Milo does what has been used in the film industry. We are going to now use them by merger of technologies. And the result is that the surgeon and the team, the AI team, will study details of the scan in the holographic zoomed images and will help identify every tumor detail in relation with surrounding structures, namely the blood vessels and the cranial nerves. So our working is also going to improve. Surgeon will operate on a virtual patient with augmented reality and technology which has been borrowed from the myocrane, which ensures every small detail of this movement and instrumentation. And so the future is working. And remember, AI would learn and evolve with every single surgery. So our proposal is that this system equips surgeons with multiple chances at the same surgery. And you can undo your mistakes and save the patient from potential intraprocedural problems. And finally, neurosurgery requires years of training. Outcomes will be varied. Complications once seen as part of learning curve. We have ICCN, which is changing the mindset by having open discussion of complications, learning from failures, not hiding behind the so-called learning curve. This learning curve should be now totally abolished by this new technology. And progress is celebrating success and embracing lessons from these setbacks. So, you want me to give some closing remarks or I'm done? Yes.
So,
I cannot see.
Does anyone have any questions?
stop the
for Dr.
sharing.
Denki?
Okay.
Thank you very much, Kiki. Kiki has also been a dear friend for a long time. When I was a resident, I remember Kiki as a very senior professor. I used to see him in conferences then. As I became a faculty, I don't know where we have not traveled together. So to all continents, we have traveled together, given lectures. Kiki has been as naughty and lively as 15 years back, even now.
50 years.
Yeah, as 50 years back, he says, but I know him for the last 15 years. So Keki's enthusiasm, he was in Manila just 2 days before. And when we talked about this conference, he said he has to come and he's in Greece today. That's the kind of enthusiasm that the younger generations will have to learn. So thank you very much. I will ask my dear friend Sanjeeva to talk, after which we will also have another talk from Deepak, and then we will go ahead and have a break for an hour. A little bit of rest also is not so bad. After that, we will have talks from both Afzal and Juma after the break. And,
Sorry, can we get the innovation
I think
committee?
after that, there are 2 more online talks. And after which I guess, Ramya, that we can call it a day after that, isn't it, Ramya?
Yes, sounds good.
Ramya, you are muted.
Yes, can you hear me?
Yes.
Yeah, sounds good. I think 4:30, Dr. Sandeep Shah and Dr. Manish Baldia will also be speaking, but that'll be after the break.
Thank you, Ramya. Thank you. I would ask Sanjeeva to. Sanjeeva is the professor at Oxford and one of very distinguished academics. And he's an excellent surgeon. His specialty is skull base, and he does a lot of. He's into a lot of innovations, which has been inspiring us. So, thank you, Sanjeeva. Please, we are waiting for to see what you are talking about.
Thank you very much. Thank you. I'm really sorry I couldn't be with you in Athens. I imagine it must be boiling. It's really hot here in the UK, so I can only imagine what Athens is like. But thank you, and thanks for putting together this fantastic symposium of really, really nice talks. I'm going to talk about a very specific bit of research that we are interested in. And it started off with vestibular schwannomas, as you'll see. But really, we're really interested in how do we pick up patients, or even anyone in general who's going to get worse, and how do you assess how people have done? And yeah, I think maybe you're still unmuted. And how do people do after after surgery? So that's yeah. Would you mind muting, Hype? I think you're. Thank you very much. Thank you. So yeah, so that's what this is really about. So this is about using wearable technology, our AI algorithms, and I'll show some preliminary data, but mostly I'll be talking about what our views are and our concepts on this. It all started with vestibular short notes. I mean, we've sort of taken it beyond that, but this is how it all started. You know, we have patients who really struggle, and they don't have to have big tumors. You know, you can have a small vestibular schwannoma. It doesn't have to be a big vestibular schwannoma, and it can be absolutely terrible. The picture on the right is the patient who very kindly shared this picture that they put on Facebook on what their life feels like. And this is what it's like when you're dizzy, not just with a VS, but with any problem. And all of us at some point may suffer with dizziness in our lives. And it is very, very disabling. So this is the problem that we were trying to address. But the difficulty we have, and I don't think it's just us in the UK. I think it's a worldwide issue, is that we measure the tumor, but we don't measure the patient. We're very, very interested in measuring the tumor. We, of course, are interested in the patient, but we don't have a good way to measure them, we feel, at the moment. And in the UK, if you look at how people measure outcomes, these are the things they look at. They look at mortality, morbidity, extent of resection, what was your tumor disease control. And this is good, of course. We've worked very hard to get very good at these things, and these things are really, really important. It's a lot of very, very good surgeons here, Ibe Keki, a lot of really good surgeons here, and I'm sure they'd all agree that this is really important. Of course it is, but it's not enough. That's what the point is here, that our technology is getting better, and we have to get better with it. So this is not enough. And if you take again vestibular schwannomas as an example, but this could apply to anybody. These are all things that we don't really measure that well, actually, to be fair, in most things. And at the end of the day, once you get very good at delivering a very good outcome with operations, you can get a near total resection, House-Brackman 1, facial nerve, all of that. You have to start looking at all of these other things. This is the next step in the evolution, isn't it? We've gotten very good at dealing with large tumors, small tumors, hearing preservation, all of those sorts of things. But it's still, their lives aren't what they were before, and we can do better. So this is what all of this is about. We want to measure what really matters. And as you know, particularly in benign disease, this is a major issue. So, 61% of these patients in VS will have, it's probably actually higher than that, but the sort of published data is sort of 61 balance dysfunction. And it's not really explained by tumor size. There are some studies that suggest that fast-growing tumors can be worse. But again, just by looking at the scans, you can't tell how bad the patient is going to be necessarily. And in the converse, I see some patients are very well with massive tumors. Okay. And the other thing we have that's quite helpful here in Oxford is a very good rehab service, but we want to know who we can send there for this vestibular rehabilitation. So we want to move away from this sort of just taking a history, maybe you come once a year, once in 6 months, whatever it is, you have a scan, you have this. We want to move that away. We want real-time data. And really that's what we've been trying to work towards, is getting this sort of real-time data where we can map their day-to-day, even hour by hour, minute by minute trajectory of what these patients are doing. We're looking at going into sleep outcomes, possibly some of the cognitive functions, all sorts of things. But at the moment, we're starting with very basic movements, balance, things like that. We started with some very basic work where we first looked what's out there. How would you measure movement activities? And the premise for me is, if I want to know how well any animal is, it's a human or your dog or your cat or whatever, you can tell that by how much they move. It's really that simple. That's my view. Okay, the more they're moving, the better shape they are. Keki's a good example of that. Keki is a little bit older, but so active. Okay, so this is a really good example of how well someone is by how active and able they are. And that's where we started. We wanted to know how much people are moving. So we looked at the current available data, and most of it actually is not in free living. It's done in a lab, and we're also doing some stuff in a lab, but it doesn't happen when you're out and about in free living. It does. Commercial companies are trying to do that, but not so much in research. And these are the areas you could try and measure. You can put it on the head, probably behind the ear is quite a quite a good one. But yeah, we're looking at wrist, ankle is good, chest. These are all areas where you can place sensors. And as Keki was showing in his talk, these sensors are all becoming very, very non-invasive, very small, easily will fit into your glasses, watches, maybe even t-shirts, shoes, whatever. And you wouldn't even notice they're there. We had a look at what was there. So I'll just go back again. We also worked out that obviously, things like straight line walking aren't great. You really have to look at more complex maneuvers, turning, head trunk coordination, gait variability, all of that kind of stuff. And that's what we were really interested in looking at. We started with a very basic thing. We just got people to wear a couple of wrist one. I teamed up with a colleague of mine who's done massive work in actually in India, China, and in the UK Biobank, showing that just with a very basic wrist one, you can get a huge amount of data. And he's got this from hundreds of thousands of patients to measure their sort of ability to move, walk, etc. This is just a little bit of preliminary data very early on in this study. We're about to publish a sort of more comprehensive bit, but this is just a little bit of preliminary data showing in the green is normal controls. In the blue, vestibular shown patients who on the pen acoustics score and things are not dizzy, and red is dizzy patients. And this is just to show that actually minute by minute, we can work out how much someone is moving. And we have algorithms from the UK Biobank data and things that show that if your movement goes down significantly, your cardiovascular risk factors go up significantly. So we use those AI algorithms here to show that actually dizzy VS patients reach that threshold where cardiovascular risk factors going up so much because they're not moving. The other interesting thing was, if you look at this graph, that this 8 to 10 o'clock time period here, is actually where they're moving the least, which we didn't quite expect. We thought it was, when at night, when it's dark, that sort of thing. So the other thing we're finding out is things aren't exactly how we think they are. And actually now in clinic, when I really start questioning patients, they say, oh yes, actually in the mornings, when I get out of bed, I'm a little bit dizzy and things, and I have to stay still for a while. So we're starting to predict when they have the problem, by what degree the problem is, and how it affects their long-term health. And so we've expanded this out massively, and we're going into all sorts of things like, measuring quality of sleep, mood, all sorts of things, in combination with using wearable technology and the sort of standard assessments we already have. We're also we need to work out the ground truth on how good our algorithms are and how good our wearable tech is. So we're also going back into the lab using Vicon. Vicon are these sensors you may have seen, is used in movies. It was actually developed in Oxford in the 1970s, but very popular in Hollywood, maybe in Bollywood, where you can mimic various characters and things by having actors wear these sort of sensors. So we're using the exact same technology that's now very well developed, a good sort of 50 years in the making, to get the ground truth about when exactly do they get the problems, how is their movement affected, what is exact normal or good movement for each individual person, and we're using algorithms to sort of then expand that out to predict for the general population. I'm very grateful for Cancer Research UK for funding some of this early work. And the idea then is to work out, what activities are people avoiding, how do they adapt, where's their fear of falling, all the way to getting early deterioration, which you don't see in a clinic. This picking up this very subtle early deterioration in a patient is very hard to drag out in a history or whatever in clinic. And that's what we want to do, starting with VS, vestibular schwannomas, but we intend to use this for everybody. And for vestibular schwannomas, we then have something we can then target. We have very good vestibular physiotherapists here who make a big difference in terms of rehab and making them better. But as I said, these digital biomarkers is what we're after for the general population. And so our plan in the long term is to plug this into NHS pathways where this wearable, in a very non-invasive way, is part of your routine care, or even if you're not a patient, maybe in the general population. Combine that with imaging, combine that with patient-reported outcomes. And we're already doing whole genome sequencing. That's a long way away where we sort of integrate all of this, but I'm just showing what the 10, 20-year plan is in terms of obtaining these massive biomarker data sets from your genes all the way to how you behave. and that's our goal here. So yeah, this is just another sort of avenue. We think one of the big things we'd like to do, and I think this would be helpful in very remote areas in the world as well. But we don't want people coming into hospitals. Really, we want all of this to happen at home, just like a lot of commercial companies are trying to do. So this kind of thing doesn't have to happen in a hospital. In fact, it shouldn't happen in a hospital. What we want this to happen is really when it's in your actual life and in as less a invasive way as possible. And as I said at the very beginning, we're starting with vestibular schwannoma, but really this is for everything beyond surgery, even in healthy individuals, really. That's our real goal. We're going to start in a very defined population where we can really build good data and understand what's happening. We're going to expand it out slowly to neurosurgery, surgery, healthy populations. And, obviously we're not the only ones doing it. Lots of big companies are doing this. This is just a couple of things I got off the internet. What Google is doing, what Whoop is doing. Everybody's in on this. Obviously, they have quite significant resources, great teams. But what we think is a real understanding of balance in the pathology, particularly in this group, and we plan to expand that out. Oxford is a great place to do this. Another 60 million has just come in a few days ago, not to us, but to some of the other complementary labs. We have the Podium Institute, which is our huge brain injury research institute. You can see that my colleagues in endocrinology are working on wearables as well, in insulin resistance. So it's quite a good place for us at the moment. There's a huge amount of interest locally, and we're really being able to tap into that. So that's really, 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 really nice for us in terms of trying to expand this work out. So that's really my talk. But to summarize, I want to say that we really need to measure what matters, so we can treat what matters, and we need to start treating the patient, not just the problem. So thank you again, and I'd like to thank it's a huge team behind this, particularly the patients, and our brain tumor charities here in the UK have been massive, and all the experts I'm working with on this. So thank you again, and thank you, IPE and the Innovation Committee. Always a pleasure to speak here.
Thank you very much. Sanjeeva has always been into disruptive things, and I'm very proud of this talk, Sanjeeva. Thank you very much. And now I'll ask another disrupting personality. Bipin Chaurasia, are you there? Bipin, are you there? Bipin, are you there? You have muted. I know. Okay, so I think there is a point. Okay, now? Okay, Deepak, are you there, Deepak?
Yes, sir. Yes, sir.
Yeah, Bipin, can you please talk? Yes, sir. Okay, Bipin will give a message first, and then Deepak, you talk, and then we take the break. And then Deepak, we talk, and then we take a break.
Hello.
Deepak, we talk, and then we take a break. Close your microphone.
Is it okay now?
No, Bipin, you talk first.
Bipin, you talk first. Bipin,
and then Deepak. Bipin, you.
And then Deepak. Bipin, you.
I'm able to.
Sorry, there is a lot of echo.
Are you listening me?
Yeah, the mic. Hello, can you hear me? Can you hear me?
Yes.
Yes.
Can you hear me?
Is it okay now?
Yes.
Hello.
Bipin, can you talk?
Bipin, can you talk, please?
Yes. Good afternoon, all of you. Good afternoon, all of you. Thank you for inviting me for this Innovation Committee meeting. And it was a wonderful meeting. Thank you, Professor Cherian, for inviting me to this wonderful meeting. He is doing a good job in designing cinema exoscope and providing low cost instruments and even the Sanma Ichthyoscope and thinking about providing the low cost modular ICU in lower middle income country, and even designing the intraoperative MRI. His innovations is very commanding for the low middle income country, and for us it's very important thing. And he's doing a good job and commanding job. I appreciate him, and wish you best of luck for his future job for the innovation committee in WFNS. I'm also I'm the chairman of the investor committee, but my job is basically for connecting the neurosurgeon worldwide. So thank you, Professor Cherian, for inviting me, and thank you again. Thanks.
We have another. We have another friend in the villa, Federico Nicolosi, who's been disruptive with his app surgeon models. So we are going to swim now, and he will talk tomorrow. But Deepak, as I was saying, we have another disruptor friend in the villa, and it is Dr. Federico Nicolosi, who's been very disruptive with his app surgeon models. And today, we are going to swim, and tomorrow Federico will talk. And what I would say is now Deepak can talk, and after that we have the break. Can you hear me, guys? Can you hear me?
We can't hear you.
Yeah, excuse me. They cannot hear me, so I have to open my microphone. Yeah, Deepak, you can talk now. Yeah, Deepak, you can talk now. And after Deepak talks, we'll have a break for 1 hour, and then we'll have a break for 1 hour, and then there are 3 more talks before we call it a day today. Fantastic talks, all of you. And Deepak, I will introduce you. He's not a doctor, but he's a amazing innovation expert when it comes to neurosurgical education. Deepak has been somebody who has started things from scratch, and he set up a 3D laboratory in Parul. And he's set up a 3D laboratory in Parul, and he will talk to you about 3D models and 3D sessions, which helps a young neurosurgeon so much. Over to you, Deepak.
Okay, thank you, sir. Are you able to see my screen, sir? Hello? Hello? Are you able to?
We can see your screen.
Yes, we can see your screen.
Okay.
And you are audible also.
Okay. Now, main thing is difficult to understand the depth perception, and so hard to explain complex anatomy like brain, skull base, vessels, and nerves. Surgical approaches visualization becomes limited. So that's why we are entering into 3D medical visualization system for see better, understand faster, and treat smarter. Okay. So doctors, surgeons, and students can visualize anatomy in true depth, surgical videos in stereoscopic 3D, and interactive education presentation. Our system supports multi-formats, 3D videos, medical images, PowerPoint presentations, and 3D anatomical models. Is a 3D model. Generally, we see in 3D, 2D, okay, on a flat screen. But I made some softwares. We can open any model in stereo 3D. We can rotate 360 degree. We can zoom, and we can see each part of the model with details. Okay. Also, we can auto rotate it. We can again reset it. That is a very important thing. I think first time anyone can make like this. Okay. Other other one software I made for stereo 3D presentation. Just wait. Okay. Just you open any video, any image, or any PowerPoint presentation in 3D. Okay. At the time of presentation, you can zoom in actual true 3D. You can zoom, you can pan, and also you can magnify special any system organ, just like is all in true 3D. Also, at the type of presentation, we can use pen. You can also select any color. Okay. Then you can also use highlighter to highlight some part. And is a laser point. So don't want to use laser pointer. Also is a okay is the main thing. And other and main I found one major problem to doctors and surgical for videos to edit the video. That's why I made a simple software. Anyone can just I show you is a video. You just mark in where you want to go, mark out, then again mark in, mark out. Automatically segments are there. Okay. Mark in, mark out. Okay. You can also change this portion through this. Okay. Like this or like this. If you want, export all clips, selected clips, just export it, or otherwise select here. You can also select here. Okay. And if you want merge all the clips in one video, just click single click here. Automatically that video will cut, and within a minute it converted and merged in proper video. So maximum time will reduce to edit, cutting, and merging. So there are lots of feature also there. Also, main thing is for 3D video, main challenging is conversion top bottom video to side by side or side by side video to top bottom. But in that software, just click one converting tab, so you can convert top bottom video into side by side or side by side into top bottom. Is a very simple, just on one click. It's saving hours of time, and it will be done within a 1 to 3 minutes only. Hello. Hello.
Yes. We are hearing you. We are hearing you.
Yeah. These are the main things, sir. And just recently, Dr. Ipcharian told I already did the setup at Parul University with the guidance of Mr. Dr. Ipcharians, and also I made all that things with the taking guidance of the Dr. Charians. Thank you.
So we have the 3D lab set up by him. It is a very large projector screen with 3D and exoscopes from Sanma, which can project the entire 3D pictures there. We can annotate there. And once a model is made, we can rotate it, show each and everything. So it is a very, very unique lab. And I think all the young residents should come and make use of it. You should come there and see how neurosurgical. I wish 20 years back we had the same kind of facility when we were learning neurosurgery. So right now, this is what we have, and it has been set up by Deepak, and I think he should be exposed to the whole world. People should understand how he does this work, and kudos to him. Thank you very much. We will start the break now, and after the break, we can go ahead and have 3 more talks. Thank you very much, everybody. Deepak, you want to show some more things?
Yeah, is our 3D screen at Parul University. Is our 3D screen at Parul University.
It's an application. Yeah, it's an application.
You have to pay for that?
No.
Pay for that? No, pay for it. No, pay for it.
Deepak,
Yes,
you are
sir.
showing something.
I just showing our screen, sir. Our screen at Parul. Is our Parul screen, sir. Thank you.
Deepak, thank you. We will close the session for now. And then we will start 1 hour later. 1 hour later, we'll start the session again.
Okay, thank you, sir. Thank you.
Thank you very much, everybody. Thank you very much.
Just to get to